Hi everyone, my topic is pyloric stenosis and is also called infantile hypertrophic pyloric stenosis. Shortened, it is HPS, and we will be looking at the normal anatomy of pyloric canal. It is located in the pylorus of the stomach. I did print off an image that is right here, but here is a closer one. It shows the pylorus, which is this whole area, and it shows the antrum, the inferior part of the stomach, pyloric canal, and the pyloric sphincter right here. The pylorus is the inferior part of the stomach and connects to the proximal part of the duodenum. Facts of HPS right here. It occurs in approximately 3 in 1,000 neonates, usually with newborns. It is male infant dominant between 2 and 6 weeks of age. It is rare for a child to be born with HPS, and it is also rare to encounter HPS in infants past 5 months of age. Causes are unknown, but genetics and environment may play a role. Hypertrophy of the circular muscle of the pylorus is an acquired condition that narrows the pyloric canal. The pyloric canal isn't actually stenotic or narrowed, but it acts as if it were after the fact of abnormally thickened surrounding muscle. Risk factors right here is sex. Earlier I mentioned that it was male dominant, and the ratio is about 4 to 6 to 1. There is race, and it's more common in Caucasians and less common in African Americans and Asians. There is also premature birth, family history, smoking during pregnancy, early antibiotic use, and bottle feeding. Sometimes it's hard to image HPS with an empty stomach, so if the stomach is empty and they aren't sure if it's pyloric stenosis, 60 to 120 milliliters of glucose water or Pedialyte is given via oral feeding or nasogastric tube to visualize the pyloric area. An overly distended stomach can move the pyloric muscle posteriorly, making sonographic imaging hard to have an accurate measure of the pyloric canal. So aspiration of gastric contents via the nasogastric tube may be required. Sonography is the best modality to diagnose HPS, which can measure the canal length, the muscle thickness, and even the channel length. This photo here is measuring the length from proximal to distal part of the echogenic central canal. This is the central canal, and these are the calipers measuring them. Patients are usually scanned supine, then right lateral decubitus if diagnosis isn't known, because you'll get the best view of imaging the transit of gastric contents into the duodenum in 2 planes. When scanning live, you will see the peristaltic and reverse peristaltic waves in the upper abdomen during and after meals because of the contents trying to escape, leading to projectile vomiting. There is a presence of moderate to severe flow on color Doppler for a significant finding of HPS. I do have some numbers to give you reliable indicators that they have pyloric stenosis. There is a long axis view of 3.5 milliliters or greater, a channel length of 17 milliliters or greater, and a pyloric muscle length of 20 milliliters or greater. So anything greater than those numbers will show HPS. I have this photo here, and here it is. It is the transverse image of the HPS, which is also known as the target sign. It has a hypoecholic muscle layer, an echogenic central canal, So overall, it has a non-uniform echo pattern with near and far fields appearing more echogenic. I also forgot to mention that when measuring this, it also is known as one of the cervix signs. Right there, cervix sign. Some signs and symptoms right here. The most frequent clinical sign is bile-free vomiting in otherwise healthy infants. There's persistent hunger, there's constipation, extreme abdominal pain, and infants will also become dehydrated and have weight loss because of not being able to keep food down or anything that goes down. There's palpation of an olive-shaped mass in right upper quadrant. Secondary signs include exaggerated gastric peristalsis and delayed gastric emptying. Here's a picture of an infant. I highlighted the throw up so that y'all will remember this for our exam. But here it is. So as the muscle thickens and elongates into the antrum, the stomach backup increases and vomiting is more constant and projectile. Here are some treatments right here. One of the standard cures of HPS is pyloromyotomy, and it is a surgical procedure in which an incision is made in the tight muscle to loosen it so the stomach can empty again. But also for those worrying mommies, it doesn't affect your baby's growth. You can also use laparoscopic, and you can also try managing the dehydration and loss of hydrochloride from the gastric juices. Thank you guys. This is my topic for pyloric stenosis, and I hope y'all enjoyed. Thank you.